to the podium. Dr. Kim is from Seoul, Korea, and will be presenting on comparison of 3-month versus 12-month dual antiplatelet therapy after coronary intervention using the contemporary drug-eluting stents with ultra-thin struts and advanced polymer technology, the Host Idea randomized clinical trial. Welcome.
Great, thanks for a nice introduction. I'm H.S. Kim from SNU Hospital. I'm glad to share the results of Host Idea RCT with you. Host Idea trial is an acronym for this intervention with next generation DES and abbreviated DAPT. That is investigator-initiated randomized open-label multi-center trial sponsored by SNU Hospital. This trial has received research funds from Biotronic and B. Brown Korea. Current guidelines recommend DAPT for 6 months in stable case and 12 months in unstable case. Third generation DES with ultra-thin struts and advanced polymer technology have theoretical benefits that minimize the risk of stent-related complications. Thus, third generation DES may allow shortened default duration of DAPT, but data are limited regarding the short-term DAPT after PCI using third generation with ultra-thin strut. We use Orsiro and Coroflex Izar stent in this trial because strut thickness of those stents are really thin, about 60 micron in small size and 80 micron in regular size, 50 and 60 microns. Both stents have used a unique drug delivery system. In case of Orsiro, they use hybrid polymer system with bioresorbable BioLute polymer matrix. And in case of Izar, they use polymer-free, propofol-based bioresorbable drug matrix. Objective of Host Idea RCT is to compare SAPT after 3-month DAPT with 12-month DAPT in all comers. Of course, we exclude STEMI, undergoing PCI with third-generation DUF with thinnest strut. We designed this trial to be pragmatic, leaving DAPT and SAPT regime at the physician's discretion. Working hypothesis is 3-month DAPT will be non-inferior to 12-month DAPT at 1 year after PCI in terms of NACE. Primary endpoint is 1-year NACE, that is composite of cardiac death, target vessel MI, clinically driven target lesion revascularization, stent thrombosis, and major bleeding defined as BARC type 3 and 5. Sample size is calculated under the following assumptions. 1-year NACE rate would be 9.5%. Non-inferiority margin was set as 3.2%. That was 1/3 of expected event rate. Attrition rate would be 5%. As a result, sample size of 2,173 patients were required. From 30 centers in South Korea, for 5 years, we enrolled 2,173 patients with de novo stenotic lesions. This is practically all common trials because patients with de novo lesion who will undergo PCI using Orsiro and Coroflex Izar stents are included. Exclusion only STEMI, cardiogenic shock, decompensated heart failure, and patients who cannot follow DAPT schedule, who requires warfarin or anticoagulant. Here are study flows. Among 2,173 patients, we actually enrolled 13 patients into either 3-month DAPT versus 12-month DAPT. About 99% was finished at 1-year follow. Here are baseline clinical profiles of 3-month versus 12-month DAPT. Mean age, 65 years old, male, more than 70%, diabetes, about 40%, CKD, about 10%, diagnosis at the index PCI, stable, about 45%, unstable, ACS, about 55%. Here's baseline angiographic profiles. Extent of CAD, 1, 2, 3 vessels disease is about 50, 30, 20%. B2C lesion constitute about 75%. Total stent length per patient is about 30 millimeters. Number of stents per patient was 1.6 stents. Median duration of depth in short group was about 100 days. Here, 360 days. The regimen of the APT were mainly clopidogrel-based. About 90% of patients were prescribed with clopidogrel-based depth, while 8% with ticagrelor, 2% with prasugrel. Here are the primary endpoint results. NACE, cardiac death, infarction, TLR, stent thrombosis, and major bleeding at 1 year was around 4% between two groups. 3-month DAPT was non-inferior to 12-month DAPT. This non-inferiority was well met. Here are landmark analysis at 3 months. Before landmark, beyond the landmark, there is no difference between two arms. Here are second endpoints, target lesion failure or major bleeding, BARC type 3 and 5. 2.5% in target lesion failure in both arms. Major bleeding is around 1.5 versus 1.9% compatible. No significant difference. Here is landmark analysis at 3 months of second endpoint. Before landmark and after landmark, target lesion failure was similar. Major bleeding was also similar between two arms. Here are all clinical outcomes at 1 year. Major bleeding, type 35, 1.5, 1.9. POCO, 6.0, 6.9. Myocardial infarction, 1.3, 1.0. Any bleeding, 2.35, 5.2, and 6.6. Type 2 bleeding, minor bleeding, 3.7, 5.0. There is no significant difference between two groups. Here are subgroup analysis. All the results are consistent regardless of subgroups. For example, in ACS patients, that is about 55% of this population, non-fatal infarction was very similar between two arms, 1.3, 1.5. We also did per protocol analysis because the adhesion rate of short DAPT was about 72%. Thus, we did PP analysis. The results are consistent of those of ITT analysis. Primary outcome, 4.0, 4.2. Target lesion failure, 2.4, 2.9. Major bleeding, 1.4 and 1.9. No statistical significant difference. About 90% of our population was treated with clopidogrel-based depth. So we checked clinical outcomes in this 90% of population. Primary endpoint is around 4%, target lesion failure around 2.5%, major bleeding 1.6, 1.8%. No difference between two different depth duration. About less than 10% use a potent agent-based depth, such as TICA and prasugrel. The results are similar. Primary endpoint, target lesion failure. Of course, major bleeding instance is a little bit higher in prolonged depth using potent agent, but it did not reach statistical significance because of the small sample size shown here. Limitations. The actual event rate, the primary outcome was lower than expected when we designed it 2015. Expected event rate was 9.5%, but actual rate was 4.1%, which is compatible to those of current studies. This made non-inferiority margin of 3.2% too wide. That was determined based on 1/3 of expected event rate, but it actually became about 78% of actual event rate. Thus, we used a new stricter margin, 1.64%, based on the actual event rate, 4.1%. Then, 3-month depth was non-inferior to 12-month. This study was an open-label trial and might have biases of non-adherence to the study protocol. Adherence rate was 72% for 3-month, 94% for 12-month group. Such a 70% or more adherence rate is compatible to those of current studies comparing to different duration of depth. One thing that we observed in the study is good performance of clopidogrel in at least Northeast Asian. Although more than half of the patients in our study presented with ACS, of course we excluded STEMI, a majority used clopidogrel, showing excellent results. In conclusion, among the general population excluding patients with STEMI, 3-month DAPT was non-inferior to 12-month depth for NACE at 1 year after PCI, using third-generation DS with ultra-thin struts. I really appreciate co-investigators of Host Idea RCT, and this result is published in circulation today. Thank you very much for your attention.
Thank you, Dr. Kim. Now we'll turn to invite Dr. Thomas Luscher, University Zurich, Switzerland, to share some comments and questions.
Well, thank you very much. This is a very, very important trial, and congratulations on a well-performed trial throughout South Korea. As an editor, I always highly estimated papers from your country, indeed. I have a question. Why did you not standardize the dual antiplatelet therapy and had prasugrel and ticagrelor as well in your population?
Yeah, in previous several trials performed in South Korea and Japan, we believe clopidogrel-based DAPT was non-inferior to the DAPT based on potent agents such as ticagrelor and prasugrel, not only in ACS patients but also in STEMI patients, because Northeast Asians are prone to bleeding and less thrombogenic, we believe. Thus, nowadays, the current practice pattern in South Korea and Japan, we adopt clopidogrel, not only in stable patients, but also unstable patients. In case of STEMI, the story may be different, but overall, we believe clopidogrel may be sufficient enough to reduce thrombotic risk compared with potent agent.
Is there any evidence that the polymorphisms that affect clopidogrel efficacy is different in Asians compared to other ethnicities?
Yeah, that's true. The prevalence of loss of function allele to C19 was definitely more prevalent in Korea, in Japan, and China than Caucasians. And the actual PRU value is a little bit higher in East Asians than Caucasians by at least 40 unit. But actual thrombotic event rate is lower in our population. Thus, we believe there is definite gap between laboratory resistance versus clinical resistance in terms of clopidogrel.
Very good. Another question relates to the two different stents. Why did you choose to select two different stents with different properties in terms of the release of substances from the struts?
We tried to compare two different stents with ultra-thin struts, but actually most physicians prefer Orcyro with many clinical evidence than Coroflex Izard. Thus, actually, we adopted a 2x2 factorial design. In that design, we tried to compare Orcyro and Izard stent, but actually, the physicians prefer Orcyro, thus we gave up the DS comparison on.
But you didn't do, did you do a sub-analysis comparing these two different stents, and was there any difference at all?
Yes, 70% of patients were treated with Osiro, 30% by Izard. We compared two different stents. As shown in subgroup analysis, there is no difference between two DS in terms of absolute event versus no interaction between two different durations of death.
You obviously excluded STEMI patients in this very cohort. What were your thoughts about doing this, and could you speculate whether this would be similar in patients with STEMI properly stented, or do you would have expected differences?
The rationale that we excluded STEMI patients in this trial is based on our previous experience. We generate many clinical data comparing shorter versus longer depth. Usually, short depth was non-inferior or even better than long-term depth. The only exception were two populations, STEMI and left main bifurcation lesion treated with multiple stenting. Our previous experience led us to exclude STEMI patients because short DAPT may not be non-inferior or may be worse than long DAPT in such as STEMI or multiple stenting for left main bifurcation lesion.
Well, thank you very much. Again, congratulations on a very well done trial.
Thank you, Dr. Lucier. Thank you, Dr. Kim. Our final presentation of this session